What I'd like to talk about is the implementation of new diagnostic tests. We heard a nice talk about the epidemiology and what we'll need with respect to treatment and vaccination to reach our goals of elimination. But one of the things we're going to need to do is to be able to address the finding of these TB cases and getting them under treatment. And it was mentioned earlier today, only about half of all new cases and about 2/3 of new smear positive cases are actually detected in the laboratory. And AFB smear microscopy is a good rapid technique for highly advanced disease, but it's something that is clearly inadequate, especially in the face of HIV. And as has already been mentioned, only about 5% of MDR TB cases actually have a laboratory confirmation of drug resistance. And as far as XDR goes, there are many XDR cases out there that we don't know about simply because we don't have the ability to test for resistance. Now, it's not only in these countries like Africa and Asia where we're seeing problems, but we have the same sort of problems in the United States in a slightly different version. And that is, if you're a smear negative culture positive patient, about 28% of the time, the physician doesn't start treatment until the results of that culture comes back. And in our good public health laboratories, it takes about 21 days to get the results of a culture. So we have thousands of our patients are smear negative culture positive, and they're walking around transmitting the disease because we're waiting for the culture. So it's very important that we develop new rapid diagnostic tests and use them in programmatic settings. And so the key needs for TB laboratory services, whether this is industrialized countries or resource-limited countries, is you need quality assured testing for patient care. All of our testing needs to have quality assurance. We need to have reliable tests that clinicians can trust and use for patient management. And we need, patients need access to diagnostic tests. So all patients should have access to the diagnostic tests they need for their treatment and care. And we need to have laboratory systems and tests that are appropriate for the setting. And there are a number of technologies that are out there that work quite well. And here's a short list of what the WHO recommended technologies are. There's microscopy, whether that be LED microscopy or Zeal-Nielsen microscopy, culture on liquid and solid media, phenotypic drug susceptibility testing, molecular drug susceptibility testing, and the most recent one, expert MTB-RIF. These, typically in our countries, these tests are used in various parts of the laboratory network, and here we just show the typical pyramid of testing where the patient enters at the bottom of the pyramid and various tests done all the way up to the National Reference Laboratory, the central level. At the lower levels, we tend to have access to smear microscopy, whether it's conventional Zeal-Nielsen microscopy or LED fluorescence microscopy. And at the very top layer, we have the more sophisticated tests of culture, solid and liquid media, drug susceptibility testing, line probe assays, and such. The newest advancement in TB testing is the automated nucleic acid amplification test, what we all call the Cepheid Gene Expert technology, which can go at these lower levels, so patients will have easier access to this. Of course, to the patient, this whole pyramid is invisible. They just have a specimen collected and gets tested. So from the patient's perspective, what is important is this entire process, this entire path of work, from when the doctor says it's time to get a specimen, the specimen's collected, it gets to the laboratory, the report comes back to the physician, and treatment begins. When we think about implementing a new diagnostic test, very often we think just about the laboratory, putting that test in the laboratory, making sure it works in the laboratory. But the program has to think about this entire cascade of events so that the time from ordering the test to doing something with the test result becomes as short as possible. And so when one thinks about implementing new diagnostic tests or new diagnostic algorithms, you have to work with the Ministry of Health and the local authorities. So the decision to implement a new test has to be done by the authorities, whether that's the Ministry of Health or the National TB Program, because we need the national program to adopt this test, put it into their testing algorithm, and make sure it's used to treat and care for patients. We need to use a phased approach, and this approach needs to be part of the National Strategic Plan for the laboratory, and for the program as well, because it's important that as we scale up laboratory services, that if we diagnose new patients, the program is capable of treating those patients, whether they have drug-susceptible TB, drug-resistant TB, or TB or HIV. So any new improvements in laboratory has to be linked to improvements in access to drugs, especially MDR drugs to treat MDR TB, and program capacity. And it has to be based on your local needs. In certain populations in your country, you're going to need a test that can detect MDR TB rapidly. In some places, you'll need a test that detects TB in HIV-infected individuals sensitively. And there are going to be slightly different tests for the different populations. And so I just want to go through an example here that's the very popular one in the world today, and that's the Expert MTB RIF test. This is a new automated test that can rapidly detect Mycobacterium tuberculosis in a specimen, and it can rapidly determine whether that specimen has TB that contains mutations that are associated with rampant resistance. And so the WHO recommends that this test should be the initial diagnostic test for persons at high risk for MDR TB or persons at high risk of having HIV TB. Now, this can be just a small subpopulation in your country, say all your treatment failures, or it can be your whole country, as is in the case in Africa. A second recommendation that is Expert MTB RIF may be used as an initial diagnostic test in conjunction with smear chest X-ray in TB suspects that don't fall into that category. But it's important to note that this test doesn't do everything. We still need to maintain our ability to do microscopy and culture for monitoring treatment and certainly doing direct susceptibility testing for resistance or susceptibility to drugs other than rifampin. So there's a lot of effort going into Expert, and this is some data that's probably about 2 months old. There are quarterly updates on the WHO website. There are a lot of machines out there. There's, as of about a month ago, there's been 750 machines that have been purchased, and they're placed in 67 countries, more than 1 million cartridges, and a cartridge is essentially one test. So about many patients are being tested with this many cartridges. And for those who saw the press release yesterday, there's been a recent decrease in the price of a cartridge. So it's been a decrease by 40%, so it's down to $10 a cartridge in countries eligible for the preferential pricing. And I believe there are like 145 countries that are eligible for that preferential pricing when you purchase it directly from the company. And Unitate also has recently announced a TB Expert project where almost $26 million will be available to assist in the rollout of Expert in 20 countries. They expect about more than 200 machines and more than 1.4 million cartridges. And it's a huge effort, and there are a lot of resources that are available, and these are just ones that are available in the Stop TB Partnership documents, but there's things such as the policy framework for implementing new diagnostics that addresses both programmatic issues and laboratory issues. There's a laboratory document here that really addresses what does the laboratory have to do. I just want to give you an idea of some of the considerations that go into when one has to consider where to do TB RIF. And one is that it's where to place this machine. These machines are going to be coming along slowly. You get 1 or 2 machines for a country, and then that's going to slowly change. In the beginning, it's going to be essential that the central or your national TB laboratory have an Expert machine and develop all the expertise in using that machine, because the National Reference Laboratory is going to be the group that will be responsible for supporting and training and quality assurance of that test throughout your country. So we need to make sure that our national reference laboratories have the capability and the experience with this technology. And then once you have the expertise in countries, you can start rolling it out. And ideally, we think it should be placed at district and sub-district level because that's where the greatest impact will be of this machine. You need to have it located where it'll serve priority populations, where perhaps in a population that has a lot of MDR TB or a population has a lot of treatment failures. But it should be a place where specimen transport is rapid. You don't want to have a test that has a turnaround time of 2 hours and it takes 2 weeks for that sample to get to the laboratory. So you need to at least start where the specimen transport is rapid, and where specimen transport isn't rapid, you should start putting resources into getting specimen transport to be more efficient. It should be placed initially in localities where it's used near operating capacity, which is 12 to 16 tests per day. We are seeing this machine being rolled out in some spots in Africa where they're doing 1 test a day, and that's a very inefficient use of that machine. And you need adequate laboratory infrastructure, which primarily has to do with electricity. Perhaps more important, though, the laboratory considerations are the programmatics considerations. That this is something that the program has to think about, the ministry has to think about, and the laboratory has to think about and work together. And very often we suggest that one puts together a national planning committee that includes the laboratory, clinicians, programmers, to think through some of these processes. And you have to know the local epidemiology of TB in your country, in your cities, in your areas, and what the TB risk groups, and you have to develop algorithms. Say, am I going to focus on TB-HIV? Am I going to focus on MDR-TB? Am I going to focus just on finding as many TB cases as possible? In some countries, you're going to have to address regulatory requirements and policies. Some places you'll have to actually change your definition of what is a case of TB, and that may take some work at the national level. There'll have to be inventory and supply chain management systems in place. Specimen transport becomes very important for areas where you don't have the patient right next to the machine. And perhaps something that's often forgotten is you need a system for rapid reporting of results. We have seen a number of cases, such as in Namibia. We have a 2-hour turnaround time in the laboratory to get the result, but it can take a month to get the result from the laboratory back to the clinician, and that's a total waste of the speed of this technique. You need quality assured first and second line DST, so the program needs to invest in their central laboratory and regional laboratories, make sure that they have good drug susceptibility testing, and at the same time, they have to make sure they have a good quality and a good quantity of first and second line anti-TB drugs. If we're going to be detecting rifampin-resistant strains, more than has been detected in the past in your program, you have to make sure you have the capacity to treat those patients. That has been a real challenge when we roll this out in some countries in Africa. Don't forget, we do still have to have quality assured microscopy and culture for treatment monitoring and for other reasons. So we have to maintain our national laboratory and the laboratory network. And we have to remember, we need to budget this. This needs to get into the national budget for all the needed testing, all the services, and all the drugs. One part will be laboratory, but one part will be program and management. So the challenges are going to be incorporating any new test, not only Cepheid, but any new test into your national TB strategic plan. So the program and the laboratory needs to work together to put together a plan that will coordinate all the implementing partners. And as we all know, that in our countries, there are many people trying to improve TB control, and they don't always work well together, and they don't always work well with the national program. And we need to have the program take a leadership role here in doing the coordination of the implementing partners. We have to have good education for the clinicians, program, and patient management, so I was glad to hear we have our social mobilization and outreach people here today, because one of your jobs will be to educate the clinicians. I can tell you some horror stories we have in Southeast Asia where the clinicians gets the result that says low positive in the Cepheid test, and they say that's not TB and they're not going to treat it. For very clearly, the rest of us in the world think that's a TB patient that needs to be treated. We need to coordinate laboratory and treatment scale up, and we have to address sustainability and affordability issues. The Global Fund, PEPFAR funds are not going to be here forever, and we need to make sure we have a strategy on how do we best make this technology sustainable and affordable. And we need to keep in mind that we have to ask the question, what services are needed for patient care? Expert is a lovely test. It's fun to do, fun to get the results back, but what's important is what is needed to improve patient care. And so that patient is going to need access to drug susceptibility testing for all relevant drugs, whether that be first or second line drugs. And we have to keep in mind that someday there's going to be another test coming along. And so in summary, Lack of laboratory services remain a crucial barrier to effective response to TB, HIV TB, and MDR TB, and we must strengthen all TB laboratory services. These new technologies are great, and they're going to make a major change, and they're going to help us a great deal, but let's not forget that we have to maintain good microscopy and culture and DST and make sure that our laboratories are properly resourced to do that, and our technicians and human resources are well trained. And then we implement these new methods to make improvements, and we do this logically and rationally and together with the program. Now, molecular diagnostics is what everyone is excited about because it has the opportunity to revolutionize TB laboratory services. These technologies are fairly simple to use. They are the same technologies that are used in other laboratories, such as in HIV laboratories, for infant diagnosis of HIV infection, so that we could integrate some of our TB testing into testing for diseases of public health importance. The other the other two aspects that are revolutionary is the ability to detect smear-negative tuberculosis very efficiently. So if you're in a population such as we see in Africa, where you're only detecting smear positives, this can double the number of cases that are detected and put on treatment. And then the other big excitement is the speed of treatment and the speed to which one can put patients on therapy. If you're a smear positive, culture positive patient, the molecular test result, which is shown in red, versus the smear result, there's not much difference in getting that test result back and putting that patient on treatment. However, if you're a smear negative culture positive patient, as I showed earlier, a third of our cases in the United States of these patients, the clinician will wait this 3 to 4 weeks before they start treatment. If you have an expert result or molecular result here, they will start treatment within 4 or 5 days. Now, for MDR TB, often they wait for the culture becomes available. They do drug susceptibility testing, and that can be anywhere from 3 to 6 months. So you're shortening the time from detection from roughly 100 days down to 5 days. And that's 5 days, and patients do better. There's better treatment outcome for those patients. And of course, if you've started them on appropriate therapy here or appropriate therapy here for these patients, you're stopping transmission. So you have a chance to improve tuberculosis control by reducing transmission. Thank you. So there's a lot of thought processes that have to go into these new diagnostics. They have a great opportunity to improve our ability to do tuberculosis control, but it's essential that the program and the laboratory work closely together that make sure that the improvements in laboratory capacity are matched with improvements in program capacity. Thank you.